As Ismail explained, there are two parts in our presentation. The first one is about the diphtheria epidemic in 2023, so a global overview, and then Franck will tell you about MSF WACA response, mainly in Nigeria.
Ça a été bien dit en
introduction. You were told about this as an introduction, but diphtheria is a bacterial infection that is most of the time airborne as far as transmission goes, with symptoms that are characterized by fever, sore throat, and pseudomembrane in the throat. You need bacteriological examination of lesions, and complications are usually seen affecting the peripheral nervous system. The treatment is DAT and antibiotics, and as far as prevention goes, well, vaccine is, of course, included in routine vaccination and very often combined with tetanus and whooping cough vaccine. Now, a bit of historical background. Between 2010 and 2022, 85 countries reported diphtheria cases, mainly in Southeast Asia and Africa. However, since 2019, the major outbreaks were seen mainly in Africa. There is also a lower vaccine coverage in Africa versus other regions of the world. And in 2023, there was a major epidemic in Western Africa, mainly with 25,000 cases reported in 2023 and 5,000 cases in 2024. Now, this very strong increase is probably due to the lower vaccine coverage against diphtheria associated with the COVID pandemic, among other factors. In the 5 MSF sections, worked on 20 sites in 6 countries to treat 23,000 patients, i.e. 75% of all cases notified by the EMOH. So Nigeria was the most affected, with 17,000 patients treated by MSF, 5,000 patients were treated in Guinea, and 1,600 in Niger in 5 sites. MSF also treated cases in Mali and Chad, but there were far fewer patients. Finally, since the large epidemic in 2007, they've followed Yemen, patients in Yemen, and there's been a new surge in 2023. There may not be a link between all these epidemics, but the dynamic is interesting for Niger and Nigeria. Indeed, if you take a look at the graph here, and if you consider the domestic data, there are 2 similar epidemic profiles. Now, there's first a first wave, and then followed by a second one. And especially, you can see that the majority of cases are reported in the Zinder region in Niger and in Kano in Nigeria. So it might suggest for trans-border exchanges between the 2 countries. In the course of the epidemic in 2023, MSF focused its response on Nigeria, shown in green here on the map. However, in the summer of 2023, MSF faced a very strong increase in the number of patients, up to 1,000 per week, mainly in Nigeria, but also in Niger and Guinea. And then the number of patients went down in the course of second quarter 2023, though the epidemic went on in 2024. With this sudden increase in summer 2023, there was a shortage of DAT at global level. And this is why, during this period, MSF and also WHO and UNICEF tried to join their forces to find DAT and make sure that the allocation of DAT was equitable between the various countries. Now, within MSF, Epicentre had to centralize data from all sites. However, the sites collected different data with different tools using different Excel files. And in order to monitor the situation in real time, firstly, Epicentre asked MSF to agree on a dictionary, on a registry of diphtheria-related variables. Then the various Excel spreadsheets were standardized using outbreak tools developed by Epicentre. And then Epicentre was then started to collect the data, and it was possible to design a dashboard to have a real-time monitoring of the epidemic and to compare the various indicators. And it is used it is also used to have a fair allocation of DAT between the different sites. Now, a few statistics. 3,000 patients, 23,000 patients were treated, majority of them women, adults, as you can see here on the age pyramid. But 66% were under 15. And there's an overrepresentation of women, probably because they are the ones who take care of the children. 61% of patients during the epidemic were hospitalized, and the crude fatality ratio was 8%. Normally, all IPD patients had to get DAT, but just one patient out of 8 could be treated with DAT, i.e. one hospitalized patient out of 5. And now I'm going to hand over to Franck to tell you about the results in this country.
Merci. Bonsoir à tous. Nous allons essayer.
Thank you, Yves, and good afternoon. Let's go to Nigeria together. And we're going to go to the state of Kano, where MSF Waka intervened for response to the outbreak, and we took care of most cases. Now, Kano is a state of Nigeria with 50 million inhabitants. It is the most densely populated state in the country, with about 44 local government areas. But the outbreak mostly focused on 6 LGAs, local government areas, and we can see that the outbreak actually started in the same local government authorities at the same time, pretty much. And yeah, there were 2 waves, 2 successive waves, which made the response a little bit more complicated. On this map, you can see that the Ungogo LGA was the one that was the most severely impacted. So for us, it's the epicenter of the outbreak. And this is exactly where MSF Waka was present before the outbreak actually started. Now, in order to respond to this outbreak that started in the 6 LGAs at the same time, MSF Waka set up 3 treatment centers in 3 hospitals, and each center was dedicated to one case profile, one specific case profile. Now, there were several challenges, and in order to face these challenges, MSF had to adapt its strategy. First of all, at the beginning of the outbreak, that's in January 2023, we started taking care of cases in a conventional way, based mostly on the experience that we had in Yemen and Afghanistan. So we set up a centralized management system in Murtala Muhammad Specialist Hospital. And all cases, no matter how severe, were actually addressed to this center. And then we implemented a referral system so that all cases could be hospitalized in that unit. And then the capacity of the center was exceeded despite an increase in the number of beds. They went from 30 to 80 and then 115.
Suite à l'augmentation des cas,
And following the increase in the number of cases, we opened a second treatment center in the infectious disease hospital, IDH. That was on week 17. But when we decided to open the center, of course, it did not solve all problems.
nous allons prendre aussi d'autres
So we
très importantes
made
de cette semaine 20.
other really important decisions during the course of weeks 27. The first thing that we did was to decide to take care of mild cases at home. And the second decision was to also rationalize the use of the anti-toxin, the DAT, and only use it for most severe cases. During week 34,
Centre de traitement
we opened a third treatment center in
à Ouazzane-Chelou-Doudado
Waziri Sheru Gidado General Hospital.
va être destiné
Now, this center was meant to take care of the simplest cases,
au service de centre de traitement
and it was more like a triage center to make sure that the other two hospitals,
soit surchargé.
MMSH and IDH, would not be overloaded with cases.
En avancée pour trier les cas simples.
So this one was more of a triage unit to take care of the simplest cases.
De la prise en charge.
Now, I want to talk about home-based care.
Pourquoi nous avons mis en place
Why did we decide to implement this? Well, the first reason
pour essayer un
is that we wanted to actually reduce the burden
de santé.
on the healthcare system because there was too much pressure with the high number of cases that came to the centers.
Dans la première vague, comme vous pouvez le
The second reason is that, as you can see here, at the end of June, we found that the number of cases was going down.
l'épidémie s'arrête.
And we actually expected the outbreak to stop. And the teams and the MSF staff were already
On assiste
exhausted. And then all of a sudden came the second wave. So
à adapter
in that case, MSF had to adapt its strategy. And now we decided to only hospitalize the most severe cases, or the moderate cases, sorry, mild cases.
et tous
And
les cas,
all
on ne prend
cases,
en hospitalisation que les cas sévères.
and only the severe cases will be hospitalized. All the mild cases will be taken care of at home.
Sévères, ce sont des cas qui
The
présentent
severe cases
obstruction de la gorge.
are those with throat obstruction and respiratory difficulties. These will be hospitalized and the others will be taken care of at home.
Cette prise en charge à domicile,
But home care, home-based care, is a difficult decision to make
décider de prendre en charge les cas
because we decide to take care of mild cases at home, and this must come with a certain number of measures.
décider de prendre en charge les cas à domicile va être accompagné d'un certain nombre de mesures de sécurité.
It's the safety measures.
On fait des activités
So what we do is that we carry out a certain number of infection prevention activities at home.
mettre en place
We also
de promotion de santé,
implement health promotion activities
à
in
recevoir
order to increase the awareness of households and to make sure that they could receive home-based care cases, prevention therapy also
de suivi en remote
for contact cases, and we also have a remote monitoring or follow-up
Quels sont
on
les
the phone for the
qu'on a pu obtenir
next 10 to 14 days. What are the results that came out of this? Well, first of all, we were able to take 6,696 cases on home-based care, which is a total of 45% of all cases that we treated during the outbreak.
Et on a aussi
And
constaté que le profil de
We
ces
also
cas
found that the
maison
profile of those cases
plus les cas adultes, un peu plus
was
âgés que les
more,
cas qui sont traités à l'hôpital.
older people than those who were hospitalized.
Létalité dans cette cohorte de
The,
patients traités à domicile sera de
lethality
0,6%.
was 0.6%, the CFR.
Uniquement les cas qui sont pris en charge
Now,
en
the cases
hospitalisation reçoivent
which were
l'antitoxine pour la
taken care in the hospital would receive DAT.
Nous savons que l'antitoxine a démontré
We know that DAT has already proven efficiency in the reduction of mortality.
toxine peut réduire la mortalité de 76%.
It can reduce mortality by up to 76%. And when the DAT therapy is started soon enough, It can
la mortalité,
reduce mortality,
ça peut,
but also
chaque jour de retard,
every day of delay in the implementation of the for each day that the treatment is not given, the mortality can actually be doubled. So that's what we found in a literature review.
Quand on regarde les données pour les
When you
cas
look
graves,
at the data for the severe cases which were treated in the system,
similaires.
you find similar results.
À mettre le traitement en place,
The later,
plus élevé est la
the
mortalité.
longer you wait to implement the treatment, the higher the mortality. So 1 day later means that you have a 6% mortality. 2 days later, the mortality is 12 or 13%.
Les données observées
So
dans nos cohortes de
the
patients
data
traités dans notre
observed in the
Epicentre
cases of
étaient semblables
severe patients
à ce que on
were
a
similar to
fait
what we
analyse.
found in our literature review.
De cette épidémie,
But the challenge
et seulement
with this outbreak
a été principalement
was
disponibilité
mostly
de l'antitoxine.
the availability of DAT.
Sur ce graphique, on peut
On this
constater
graph,
la proportion de patients
you
qui ont
see
été traités
the
avec
proportion of patients that received the DAT throughout the outbreak.
Au début de l'épidémie,
As I said, at the beginning of the outbreak, the majority of cases received the antitoxin. And then,
la semaine 3,
soon after, on week 3, we found that there was a partial shortage of that. And so we realized that we would no longer be able to administer DAT to the majority of cases. And at the end of 2023 and during the first 5 weeks of 2024, we faced a complete shortage of that. And therefore, no patient received antitoxin during that period of time.
La méta-analyse et les protocoles suggèrent
So the literature review and the protocols suggest that a serious case of diphtheria should receive at least 40,000 units of that. That's the protocol that we have implemented for severe cases.
inspirés de notre expérience.
We took our inspiration from the experience that we had from past outbreaks.
60% des cas que
60% of the cases that we received were serious cases.
donc normalement devaient recevoir.
So they should have received that.
Sur ce graphique, on peut
And
constater
on this
que
graph, you see
5% des cas
that
sévères
in 5%
une dose inférieure à 40 000 unités.
of 25% received a dosage that was lower than 40,000 units.
Devaient recevoir plus de
Because, as I said, severe cases should receive more than 40,000 units. And in that case, 25% of them received less because there was a shortage. So we had to adapt our strategies and decrease the dose that was administered to the patients.
Je vais laisser la parole à Yves pour la conclusion. Merci.
And I'll give the floor back to Yves for the conclusion.
En conclusion,
As a conclusion,
on peut dire que on a vu
we saw
la présentation que
that
durant l'année 2023,
during 2023, West Africa experienced one of its
la plupart des cas ont été
largest outbreak,
au Nigeria,
mostly in the state of Kano.
même sur le déclin.
In Nigeria, the outbreak is now declining, but it's still continuing in 2024. MSF
Au cours de cette épidémie,
took care of most patients during the outbreak, but we had to face constraints, especially resources, limited capacity of hospitals, and limited DAT stock.
face à ces
So,
contraintes, une coordination entre
because of all these constraints,
les pays et puis entre différents partenaires.
we started a coordination among MSF sections and also between the countries and the outside partners
Allocation équitable de
in order to, for example, better allocate the antitoxin between the countries. And in Kano specifically, MSF Waka implemented a certain number of strategies to face these resource-based constraints. For example, we started home-based care and suboptimal dosage for severe patients.
Il y a encore beaucoup d'analyses
There are still
qui doivent être effectuées
studies in progress to better understand
la sécurité des différentes stratégies qui ont été mises en place.
safety of those strategies and the efficiency of these strategies. Now, how can we better prepare for future outbreaks?
Pour augmenter
Well, first of all, we have to increase the available stocks of DAT, and also we need to increase the response capacity in terms of production. We also need to invest in alternative treatments through research and development. And we know that diphtheria is a disease that can be avoided with vaccination. So the control of epidemics and outbreaks means that we need to have a better coverage of vulnerable populations. Thank you.